Yeah, good evening once again. So this is our final lecture on this basic certificate course in wound management. So I welcome all of you once again to the this forum. So today, as Dr. Thusitha mentioned, we have 3 lectures. The first lecture is going to you're going to have Dr. Thushan Gunarathne's lecture. Last time also I have introduced him. He's a consultant vascular surgeon attached to the Prof unit, NHSL. He's a senior lecturer in University of Colombo Medical Faculty. So without any further ado, I will I'll ask Dr. Thushan to start today's lecture because we have another bonus lecture also today. So Thushan, I can see your slides very clearly. Thushan, over to you. Thank you. Thank you, Thushan. Please start.
Okay, right. Sorry. Thanks, Prof. Samadhi. Let me get my slides on board. Right. Okay. Excellent. Hope I'm loud and clear.
Yes,
So this
yes.
is a very thanks. It's a short talk. We talk a little bit about something very important in palliative care as part of wound care as well. Most of these issues do come with patients who are bedbound, terminally ill, chronically ill. And this is going to be something all of us are going to encounter at some point in our practice as well as in our work. So let's just try and see how we can make things better for these patients. So topic is about treatment and prevention of bed sores. So over the next half an hour or so, let me just try and take you through a few things and few important things, at least to know what a bed sore is, a bit of pathophysiology as to why all of that. Try and see how we can categorize these ulcers because the management slightly differs based on the various staging or the severity of the ulcer, how we do treat it, and most importantly, how we can prevent this from happening. So first of all, what is a pressure ulcer? And we have different terms: decubitus ulcer, pressure ulcer, bed sores. Essentially, those who have seen, we know what this is about, and we have seen this often, more often than not. Unfortunately, neglected, ill-managed, left alone, discarded. We put them as things that we can't treat and let them suffer and succumb to these ulcers. In essentially, it's a pressure ulcer, and basically what happens is there is an element of skin perfusion. If the pressure on a skin exceeds 35 millimeters of mercury for anything longer than 5 minutes or so, it creates certain effects on the tissue. And if that pressure that is localized on the skin or the underlying tissue is prolonged, then that is going to cause an ulceration. Now, how this happens is you got to first see that regardless, it happens on certain areas, and that is important to understand because just pressing on the skin itself cannot cause pressure ulcers, often not, because it's got to hit back against something that doesn't allow it to move around. So normally it happens over an area of bony prominence. So soft tissue over the bone gets compressed because the bone doesn't move with pressure. So when the pressure on that area exceeds the normal capillary pressure, and that's about 25 to 30 millimeters of mercury, what happens is it causes damage. There's damage to the capillaries, to the small blood vessels initially, and that causes certain changes. We see what those changes are. Initially, it's a bursting or a shearing of those blood vessels, and then it ultimately leads to impaired perfusion. When there's impaired perfusion, there's going to be ischemia. Ischemia, when it's profound and there's permanent cell death, will lead to necrosis, and ultimately it's going to be a tissue break, ulceration, and a pressure sore. So it's important that we realize that there are three main important types of forces that we're dealing with. And it's important we are aware of all these three forces, because we often consider pressure ulcers as only period group pressure. Now, the pressure that we talk about is basically a constant pressure that's put on any part of the body. Which is what we just talked about. Just pressure applied for a long time on the same place. However, there are two other types of forces here. One is called friction, the one is called shear. So friction is when the skin rubs against some clothing or bedding. Uh, Basically, it's rubbing against something immovable. And when that happens, the skin becomes very fragile and more vulnerable to injury. Shearing is something slightly similar but bit different, in the sense that shearing happens when the two surfaces move in the opposite directions. So one classic example is patients who are kept head up or propped up, elevated on a bed for you know quite a big degree of elevation. The patient tends to slide down. As it slides down, it causes shear effects, because in a sense the bed mattress actually appears to be causing an opposite effect on the skin, and the skin folds off. It folds off and causes shearing of skin, and this can lead to skin tearing, skin rupture, uh, whereas friction and pressure might cause blistering. So it's important that we look at all these three types of forces when we're managing a patient. So just to recap, there is pressure on the skin that is unrelieved. It is persistent, it's constant for whatever reason. It squeezes the tiny blood vessels which supply the skin. And once that happens, the nutrients, they are deprived of oxygen and nutrients to the skin. If it is transient, it is fine, but if it is persistent, there's going to be chronic hypoxia leading to tissue death and ultimately pressure necrosis. And also important that it requires some form of hard surface, and there's normally a bony prominence. So again, to remind ourselves, the direct causes are very clear. This doesn't happen in everybody, so there has to be some form of impairment, because we would never stay in the same place for such a long time. We'll always move around. So these forces, the pressure, the shear, the friction, have to be combined with a patient who's immobile, who might be having loss of sensation, for example, neuropathy, people who are in strokes, who are paralyzed, who are quadriplegic. So there's loss of sensation, and for whatever reason, the patient cannot move around. And it's always a combination of these pathologies. We got to also remember that there are other causes, the indirect causes, and and because of the various disease process the patient has, which could be a cancer, which could be a stroke, which could be a chronic wound, chronic disease, immobility, age, there are going to be multiple problems in mobility, nutrition, various comorbidities, skin, aging, frailty. They might be incontinent, having mental health issues. So all these factors will lead to these special ulcers to be formed. So it's really important that we don't purely simply look at the wound itself, but pay attention to these direct causes as well as the indirect causes when we treat such a patient. So where I talkers, and I put various pictures so that we appreciate the fact that the pressure ulcers happen on areas based on how the patient is staying. And this often we feel is only for patients who are lying on a bed. It's not the case. Patients who are lying on a chair, who are on a wheelchair, who have been propped up in the bed for a long time. Some old patients are kept on couches for a long time. Some people are kept prone, supine, on sides. So based on how the patient is staying, you'll find. Sorry, I will speak louder, but if it's not clear, please voice out, and I'll try and adjust my mic settings. So based on, beg your pardon, based on how the patient lies, you find that the sites of the pressure ulcers are different. If the patient is supine, there are common areas. If the patient is prone, there will be different areas. If the patient on a wheelchair, there will be different areas. So just keep a mental picture of these images, and appreciate that whatever uh, patient position the patient has. You must look at the particular relevant areas when you're inspecting, not simply for active pressure ulcers, but also if you want to prevent pressure ulcers to look for at-risk sites. If you look at the commonest one, and this is the commonest presentation, we see patients who are lying supine for a long time on a bed, and any of these areas are actually vulnerable when it comes to pressure ulceration. Yeah, because the patient's head is lying on the back, the occiput, the shoulder blades, the elbows, the buttocks, the sacrum, then the inner knees, because the knees tend to rub against each other, the heel pad. So all of these areas are common areas. So be mindful of what these areas can be. And again, remember, it is often over a bony prominence. Right. Now, let's see how we can try and put some numbers into the way we describe or discuss an ulcer. Because if you're documenting ulceration or at-risk lesion, it's really important to document properly so that somebody else who's going to look after the patient or another carer will know exactly how bad things are. And it also helps to figure out whether things are improving or not. A small recap here, and this is just to remind ourselves that there are different layers of the skin. There is the epidermis, the dermis, and the subcutaneous layer. And we need to remember this purely because as we talk about the um, staging, it all depends on the depth, much like our burn injuries. It's also important that the structures that are there in the various stages are different, layers rather different. For example, the epidermis is just the outside skin, and most of that skin is actually dead. When it comes to dermis, you have the various contributions of the blood vessels, nerves, sweat glands, etc. And then you have the subcutaneous layer, which is where you see the fat cells, and subsequently below that we have the muscles and the fascia under the muscles. So the different layers are important to figure out so that you can appreciate how the staging works. Right. So the classic classification, and there are many classifications. The classic one we talk about is the NPUAP classification. That's the National Pressure Ulcer Advisory, Pressure Ulcer Prevention Advisory Panel classification. We talk about 4 stages. Stage 1 being is just a simple blanching erythema with an intact epidermis. And if you remember, I talked the first thing that happens when there's increased pressure is the capillaries they rupture. As they rupture, there's going to be erythema. So it's just erythema that non-blanches. Blanching is when you press on that particular area of redness, the color fades and goes back, but it comes again as you remove the pressure. If you press your finger down, it becomes white. If you remove the finger again, it becomes red again. If it doesn't do that, then that is a fixed issue, and that is a non-blanching erythema. Any inflammation will cause blanching erythema. That's different to non-blanching erythema. Okay, stage 2 is a partial thickness ulcer that involves the epidermis and the dermis. If it goes beyond the dermis and you see subcutaneous tissue being involved, then that is going to be stage 3. And the pictures on the right side correspond to the various types of ulceration and the way you appreciate it and look at the wound. Lastly, you got a stage 4, and this is when it basically goes beyond the subcutaneous layer and through fascia. And you see muscles, bones, tendons, all various type of stuff. And these are the bad wounds that are extremely difficult to sort out and heal. But remember, ulcers don't go straight to stage 4. They always go through the 4 stages. So if you've seen an ulcer with stage 4, you got to appreciate that they've actually gone through stage 1, stage 2, stage 3 unnoticed and uncared for. Right, and again, the similar sort of picture, just to recap again with appreciation to the different layers of skin. If the epidermis is purely involved, that's a stage 1. If it starts involving dermis, then becomes a stage 2. As it breaches into the subcutaneous layer, then you have the stage 3. And as you breach the fascial layer and into deep tissue, then that is a stage 4. The NPUAP talks about 2 different types of things apart from these 4 stages. they talk about what's called suspected deep tissue injury, and also something called unstageable. Might be bit unnecessary to be that specific in this forum, but just be aware there's something called SDTI rather, and something called unstageable, and these are purely used for documentation rather than for management purposes. So, how do you know what's going on? And of course, ulceration is the last thing, and it's something we want to avoid. But if you do want to catch things early, how do you? What are the symptoms of a early pressure ulcer? Of course, the erythema is something you will see, the non-blanching erythema. So if you see unusual changes in the color or the texture of the skin, that is a sign of something going on. Sometimes things might be brewing inside with intact skin. The ulcer happens purely because the skin breaches and ruptures with the pressure of the pus and the collection fluid underneath. So if you feel any swelling, any discharge that is noticeable, any bogginess under skin, if that area feels cooler, warmer, the patient complains of tenderness, for example, there's pain, then that's different because those are signs of a problem happening. Just excuse me for a quick second. Hello? Gunarathne? So, hi, sorry, apologies. Um, so those are the symptoms that one would look for. We also got to be aware of what problems can happen from a pressure ulcer, and these are the complications that are associated with it. And importantly, things like infection can progress to involving the surrounding subcutaneous tissue and causing cellulitis. If it is very deep, it can actually go into the nearby bone, joint, causing arthritis, septic arthritis, osteomyelitis, chronic osteomyelitis, can lead to sepsis because of bloodstream infection. Long-standing pressure ulcers can lead to what's called margarine ulceration, which could ultimately lead to squamous cell cancers. So these are things that one might need to be aware of when you look for complications. So just looking at this sort of patient, and you will appreciate the picture we saw earlier. This is a classic stage 4 pressure ulcer. You can see how it is going deep, well deep into the structures underneath. When you see the yellow stuff, that's a slough, it has to be a stage 3 lesion at least. When you see stuff underneath the fascia, cavities going into the deep spaces into the sacrum region, then this is stage 4 lesion. Similar picture, and you'll find different areas of the skin will be at different stages, and it's important to appreciate and understand. Like we do for a burn injury, you will have stage 1 skin in different areas, stage 2 skin in different areas, stage 3 and stage 4. And appreciating the percentage of this is important when you look for management and looking at follow-up of how your treatment is working. So few little things. So stage 2 will never have slough because it is simply epidermis and dermis. Only once it breaches the subcutaneous layer, you'll find the fatty, sloughy color, and that is there in the stage 3 lesions. Again, one important thing is just because the wound heals back or wound gets better, we never backstage or downgrade an ulcer. It's a healing stage 3. It doesn't become a stage 2. It's important when you discuss and document something. The pressure ulcer does not come up on its category of staging. Once it's stage 4, it's always going to be stage 4 that is healing or healed. You will document as a healed stage 4. Right. How do we treat these patients? There are first few important principles here, and one of the most important principles is to stop further damage. Because unless you stop further damage, you can't treat what is already damaged. And this is primarily about managing those forces I talked about, the force of pressure, forces of friction, and forces of shear. And there are various methods we can use to do this. Um, This involves things like repositioning, having a turning chart. For a patient on a bed, this has to be done every couple of hours. Patient on a wheelchair, a patient needs to adjust or be adjusted every 15 minutes. Using of support surfaces like mattresses, cushions, water beds, air mattresses, all very important things. And if these are not available, using whatever you can in terms of extra padding. Sometimes it could be a glove that is filled with water to be kept under the heel, for example. Whatever support surfaces you can use in your place, in your practice, to try and make sure that the pressure, the further damage is actually controlled. Now, as you prevent further damage, it's really important you take care of what is already damaged and try and heal it. And this involves good wound care. So we talked about a lot of these things in the previous weeks. Uh, really important about having a good wound bed preparation, cleaning, using appropriate dressings. It's really important that we try and prevent contamination, prevent infection, and then really important to look for regular monitoring, because it's important that you keep on persisting with these ulcers because they're difficult to heal. Sometimes debridement has to be done, and that is of sorry because of uh, you cannot leave unhealthy tissue behind. They can be focused for infection. So infected, damaged, dead tissue, fascia that is useless and unhealthy, they have to be removed. And this can be done with various techniques. We talked about debridement last week, which could be surgical debridement. Sometimes the dressings alone can be used for debridement with autolysis, hydrostatic pressure if available, various things like that. In rare instances, especially for people who are otherwise well and who are fit for it, reconstructive surgical options are there to try and fill up those dead spaces. And these are normally done for people who may end up with things like osteomyelitis and septic arthritis. Um, and these are very complex stuff, which involves fecal and urinary diversion, for example. I think what is most important is number one, that is preventing further damage, and what is more important at the same time is to ensure that we optimize the patient's status, because those indirect forces need to be controlled. If you remember the initial slide that we had of direct causes and indirect causes, those indirect causes need to be looked after. Ensuring the patient has good nutrition, because nutrition is very key and crucial for proper wound healing. Pain control, controlling infection, and you need to decide as to whether to swab these wounds with just contamination. You take samples for tissue for culture. You treat them with oral or parenteral antibiotics, for example. That's the decision you have to make when you see the wounds. These patients need support for their mindset. Really important. The mindset is sorted out, and that will help a lot in terms of wound healing. Um, these patients are immobile on a bed, so we need a lot of carers, and getting them on board is equally important. Um, this is basically a summary of what we talked about a patient with a blood ulcer or a pressure sore. And this just talks about the various components. Um, how to optimize a patient, how to get a multidisciplinary team involved, whether you debride, how to optimize the wound bed, um, monitoring, etc.
Excuse me, Dr. Thushan, please.
Yeah, let's see if we
Somebody is
can.
not muted a microphone. Yeah, yes, you can go ahead.
That's okay. Yeah,
Please.
thanks. So the last bit we're going to talk about is prevention, and that is very very important, because we all know once a patient has a pressure ulcer, it's very very difficult, time consuming, um, costly affair to try and heal a pressure ulcer. Prevention is about first being awareness about this problem. And it's really important that patients are risk assessed to decide whether they're at risk of having pressure ulcers. I'll talk a little bit about it. Let's just go back. So let me just talk about the scale, and it's something that is often used in the management of ulcer risk prediction. It's called a Braden scale, and there are six there are 6 components to this: patient sensory perception, the degree of moisture the patient is exposed to, the degree of activity the patient gets involved to, how mobile the patient is, patient's nutritional status, and talking about friction and shear and how these forces act on the patient. And each of these 6 categories have subcategories in terms of quantifying how these categories are. And based on this pressurized risk stratification system or prediction system, and if you grade and scale, we talk about how much of a risk the patient is. So just read about this. I don't want to talk too much about it, but this is very important and actually allows you to think as to what I should look for when I'm looking at a patient, even if you're not actually using the scale. Be mindful of looking at these 6 features to decide, is my patient at risk of having a pressure ulcer? So once you do that, it's really important that you do a systematic assessment of the skin. And again, be mindful of the picture I showed with the various positions, depending on what the common position of your patient is, to look at those sides and see, is my patient having at-risk lesions? Once that is done, you must make sure that you try and reduce the risk factors. This could be educating the patient about shifting the weight frequently, carers doing it, looking at specialty wheelchairs, specialty beds, specialty mattresses that will help for these. They are costly, but if patient can afford, we could actually offer these things to them. It's really important that you maintain good quality of skin, and that involves, especially the dry skin that breaks very quickly, as well as the macerated skin that's going to become soggy and injured very quickly. So maintaining a good moisture of the skin is very important. If it's very dry, do try and use moisturizing solutions, moisturizing creams. If it is macerated, it's probably because the patient's skin is getting exposed to sweat, urine, or feces, and we need to be looking into it and try and avoiding that. Elevation of the bed, very important, to make sure that the patient's um, bed end is not elevated too much. Anything more than 30 degrees, your shear stress is increased a lot. And very important that you be mindful of how the patient is positioned. And again, patient and family education. There's something called a 5 pillow rule. If a patient is being kept on a bed, and um, think about this in your practice, how to use these pillows, how to have a pillow under the leg to keep the heels elevated, to have a pillow between the ankles, it is placed on the side so the ankles and the knees don't get pressed and squashed together. So pillow between the ankles, pillow between the knees, pillow behind the back, pillow under the head. All important things that you should think about when you're trying to minimize pressure on these pressure sites. One last slide. Not everything that looks like pressure source are pressure source. So mindful that there are various other reasons why you might have different presentations that look like pressure source. There can be hidradenitis, perineal abscesses, perineal dermatitis, candida, fungal infections are not uncommon in this category of patients. So be mindful of not missing out on something that is correctable and treatable in a different method to the ones we talked about. So that's basically the little bit of talk I want to do. Hope you were able to appreciate what a pressure sore is. Appreciate the fact that there are 3 different types of forces involved: direct pressure, shear, and friction. How we are going to diagnose or find the symptoms of a pressure ulcer, and if you do diagnose, how we stage it, and that is based on the skin depth, and how we can do it clinically is important by looking at the depth of the wound, presence of slough, the non-blanching erythema for stage 1, and the presence of deep tissue structures for stage 4. How we are going to treat this patient, the important principles of preventing further damage, important principles of avoiding minimizing the risk factors, important principles of wound care, and important things about having adjuncts to ensure that the indirect causes are treated. Lastly, more importantly, I think is about prevention. And if we do this early, we can prevent all this from happening. Happy to take any questions, or we can have a small chat at the end if time permits. Prof. Samadhi, back to
Yeah.
you.
Thank you, Dr. Thushan. I think we have little time, so I will open the floor for any questions or any clarifications. You can ask Dr. Thushan. Anything on the chat box?
Sir, regarding the use of mattress, what is more beneficial for the patient? Is it the air mattress or the water mattress?
So basically, these are very costly things. Water mattress is of course a lot cheaper. Air mattress works in a different way. It actually has different chambers, and the mechanism of the air mattress allows the chambers to be filled and refilled in a timely rhythmic manner. So different chambers are filled in different times. So essentially, it is like having a turning chart on the patient because the pressure distribution is changed. Water mattress basically allows you to have a soft cushion. So they're both good. Of course, the air mattress would be the better thing, and there are different types of air mattresses. There are air mattresses that actually are just filled with air, and there are more expensive ones that have chambers that change with time. Uh, so the air mattress is good, but they're very expensive, and one can be afforded. I hope that answered the question.
Yes, sir. Is there a permission for antibiotic for routine antibiotic using for pressure ulcers? Because since we discussed previously for chronic ulcers, we are not routine using antibiotic. Is there a space since there is high chance of getting infected because of the stagnation of the patient? Is there a routine use for antibiotics?
Um, so I think the principles of wound care are there for all these types of chronic wounds, and you are right. Essentially, it's a chronic wound, and the principles that we talked about last time around are still applicable. The use of antibiotics, you got to be very careful. Um, Most of all these wounds are contaminated, and he's trying figuring out which one of these wounds actually infected. Easier said than done. Not the easiest thing to be able to do. Sometimes we make mistakes as well. I wouldn't consider routing antibiotics for all. That's probably a bad thing to do. They're going to cause more harm than good, especially with things like antibiotic-induced colitis as well as resistance. Um, so I think it has to be used appropriately. And if using, you got to be very careful about when you swab as well. More often, what happens is we justify the use of antibiotics by doing a wound swab from the pressure ulcer or diabetic foot for any matter, and we justify that based on the presence of a swab organism. But the reality is it's just a contamination. It's an interesting topic, but just because there's a bug doesn't mean there's infection going on. Two different things. So to answer your question, it would be no. I would not consider using routine antibiotics for any patient with ulceration. Saying that, how to decide on whether it's infected or not, sometimes there's a small gray area when it's in the borderline category, and then you must decide whether you do a swab culture or ideally clean the wound, cleanse the wound, and take a more deep tissue sample, and you look at the various features of local infection as well as systemic infection to do those things. And that's same for any type of chronic wound, including diabetic foot infections.
I can add another aspect of this. If you are using antibiotics, you must know what the sensitivity pattern of your area. Not not the same for the whole of Sri Lanka. Colombo is different to Gampaha, is different to Kandy. So you should know the actual sensitivity pattern and your common causative agents as well.
Okay. Any other questions? or clarifications?
So, how frequently should you change the dressing in a bed? So, usually it is very complicated and very like difficult patient moving and all. Like, how would you recommend?
It's one of those very difficult questions and a very common question that is asked. One common question is what dressing we use on pressure ulcers, and the second thing is how often you change it. And for me, I can't give you a right or wrong answer. So say this. Again, I think we use the principles to talk about how we dress a grade 1 ulcer is different from a stage 4 ulcer. It's really important you appreciate that. On stage 1 ulcer is just a skin breach. All you got to do, epidermis breach. All you got to do is have adequate padding, a bit of moisture maintenance on it, maybe hydrogel dressing, and 48 hours that wound will heal. Stage 2, stage 3 are different, but the good thing is it's not going too deep. And then you will think about the various types of dressings based on the wound, the way the wound looks. If it's too dry, too wet, how you manage the moisture. This is mainly about moisture balance, I think, rather than infection control with these dressings. Um, Stage 4 wounds are very difficult to manage. They are going to be exceedingly uncomfortable, a lot of exudate, a lot of weeping, a lot of offensive smelling and discharge. And you need to use specific dressings for that purpose. Dressings that absorb moisture, for example, dressings that will help to absorb the odor, for example. Again, how do you put the dressing? Can you put plasters? Because the skin around the wound is so fragile, so delicate. The plasters sometimes tear off the skin. Do we not put any plaster and just put a padding? So all very difficult, and they are very individualized care. Difficult for me to say use this, and we use various types. Can we use a vac machine, for example? So different dressings are available. The frequency of dressings for me is about the wound, and the wound will tell you how to dress the wound. Some wounds, especially the ones that get contaminated, especially with feces and urine, they have to be changed sometimes twice or thrice a day. You cannot have urine contamination. Low pH of urine will destroy the skin. Feces causes a higher pH, and that destroys the skin. Sweat will destroy the skin. So if the wound is macerated, that is telling you that the dressing frequency is not enough. If the wound is very dry, it's telling you that you're not using enough moisture to the wound. So I think you have to judge the wound and decide what you use. And it's difficult for me to say, and I'm sure Tushita can also come in and tell out, give some opinion. It's difficult to say use this dressing and to do it this frequently, because it's so individualized, and the same wound will change with time.
To add to that, Thushan, what I do practice is that there are several important things in these wounds. I mean, these are they are there to stay. The patients are actually our palliative patients. They go on. It's very difficult to manage, and we need frequent dressing changes as well. They will take a long time to heal with the contaminations and all. So there will be you cannot compare a foot wound, a chronic foot wound, to this, because the chronic foot wound we can get away with uh, uh, maybe weekly dressings, so every 4th day dressings, like, but not these ones. These ones need frequent dressings. Like if it is contaminated with feces or urine, so you need a dressing. So most of the time, it's a waste to put expensive dressings on these wounds. So you should use the cheapest dressing. And the fact that these wounds are closer to the heart, I think they are. If we uh, do this turning table, and if we uh, properly alleviate the pressure, um, these wounds will heal faster than leg wounds and all. So you just need to maintain moisture. Just use what I do is just use a gel and get the caretaker trained to do the dressing change. And reviews are as and when necessary or routinely in about 2 weeks. So it's going to take that long. So that's I think that is a cheaper and a better way to practice. That's what I do. So is there any arguments on that? I mean, the question is what dressing to use. My direct answer is use the cheapest dressing, and that can be used frequently and available in the closest drugstore.
Yeah, I totally agree with Thusitha, because when it comes to practical issue, now we are doing home visits. Now, in my experience, if you visit 5 homes with palliative patients, out of 3 you get these bed sores and all these wounds, because it's very, very frequent and they are suffering. And as you very correctly mentioned, the cheapest and the available dressing is, I think, that is the most suitable, and maintaining the moisture is the key point, and the principles of mood management. And Dr. Thusitha very correctly mentioned about the training of the caregiver, because you cannot go every day or every other day. So you have to have whoever the caregiver, the primary caregiver, if there is a caretaker, it's very important to train. So you cannot train the caregiver as a theater nurse or you are a good assistant, but something he or she might do for the patient. So that is, building of the trust and the rapport with the caregiver and the patient. So the results are incredible. So that I agree with Thusitha. And Thusitha, another question to you: how to find out the sensitivity for different areas? Where is the information available about the antibiotic sensitivity you pointed out? You raised that point.
Yeah, good question. Yeah. What I do is practically I ask the wards in the nearby hospitals what they use, what are the antibiotics, the high antibiotics and low antibiotics. What do you use, and what are the pathogens that you encounter these days? Basically, surgical wards. So if they are using, say, Cipro, if it answers, that's your sensitivity. That's the baseline sensitivity. And say if they are using meropenem, piptas, and all that, so that's basically you are dealing with. The problem is with the sewers of our hospitals. They are not treated. So basically, a hospital gives it produces resistance, and it actually distributes resistance as well. So you can safely argue that the resistant bugs in the hospital, they will eventually come to your house as well. So and of course the antibiotic policies and all, you know how it works. You just ask the surgical wards what they use and what they encounter, and it changes.
Anything else? And I think Thusitha, Thushan, and I can see Hilary also. So in my opinion and my, practical experience, most of these patients who are bedridden and, the terminally ill with all these wounds, pressure ulcers, things, their nutrition is really, really poor. So I think we have to add something on their nutrition as well. No, it will patas do the wound healing also. Any comments?
Yeah, actually, Thushan mentioned this in
Yeah.
in his presentation as
Previous
well. Yeah. So to go a little deeper into this, actually, it's very difficult to feed a palliative patient, and you can actually at some points you can argue that whether these patients should be fed. If you feed, if you hydrate, the patient will live longer. So you are basically extending suffering. So that's a different issue for a different day. So in this particular instance about the wounds, to get the wound healing, you have to have correct HB, correct proteins, and all that. So, and especially to get the wound healing as well as to prevent other pressure ulcers, you have to uh, have the correct moisture, correct hydration. Skin hydration is very important. So the patient should be hydrated properly. Depending on his other ailments, the sometimes you cannot hydrate to the level that you want. You have to discuss with the primary physician as well, and you cannot correct the proteins to that level. We can't use high doses, high protein diets and all. Probably the kidneys are gone. So you have to discuss with them as well. So palliative care, palliative wound care, all this is multidisciplinary things. You have to always discuss with the other groups. So in a nutshell, you must look into these things: HB, proteins, and skin hydration. I guess everybody knows how to assess the skin hydration and all. So
Yeah.
optimize on those issues, and to the egg white is the best. Oral route, enteric route is the best. So and there are expensive preparations. So you can, I mean, depending on the affordability, you can decide, but simpler, cheaper ones are still good for and produce good results. Another thing to look into is that whether the patient can swallow, whether he's in a on a tube or some sort of a tube, and whether they have ostomies. And how is your nutritional treatment going to affect those ostomies? So that is something to think about.
Yeah, good. Because I mentioned again, it is very much attached with the culture in Sri Lankan culture also. Because we feel very, happy when our patients are eating, especially rice. If they are not eating, so we think this is not good. So anyway, why I mention again, in our annual academic sessions, this year college oration will be Dr. Renuka Jayatis will talk about whether to feed or not to feed in palliative setting. So very quite interesting topic. Is there anything else? If not, then thank you, Thushan, for your valuable time and your lecture. So now we'll move on to our next session. That is about the bonus lecture. Am I right, Thusitha? Dr.
Yes.
Hilary will,
Yes,
Dr. Hilary will talk about, it's a very rare, I haven't heard also, the contaminated wounds, about contaminated wounds. Let me introduce Dr. Hilary. He's a consultant urologist, urological surgeon attached to District General Hospital, Monaragala. And he's our council member. And having a, vast experience in urological management. So Dr. Hilary will talk about this very important area. So about now contamination, with how the wounds are reacting, all these contaminations, and what are the measures we could take, and what are the challenges and how to overcome. So it will be a very interesting lecture. So Dr. Hilary Fernando, over to you.
Thank you very much, Professor Samadhi Rajapaksa, for that kind introduction. And
Dr. Hilary, maybe I think your connection is not that clear. I think it's your connection. Yeah. That's okay.
So can you?
Now better. You are not audible.
I think it's better for Hilary to send the presentation to you, Professor Samadhi, and you can share it.
Yeah.
I think your connection is much better. So then
we'll see what
he
Hilary
will have
wants to do.
He will have a better bandwidth for voice.
Yeah. So I can help if Hilary permits me. But until Hilary comes back, no, your connection is very poor.
Can you hear me? I think
yes,
I'm back.
Yes.
The presentation with the.
We can see you. We can see not you, sorry. We can see the slides and we can hear. Anyway,
what I'll do, I will send the presentation to Professor Samadhi. It'll take a little while.
But now you are clear. You can continue.
Okay.
Yeah,
it's very clear. Yeah, continue.
Okay, so can you all hear me now?
Yeah, super.
Okay, so today I'm going to talk to you all about the management of wounds with frequent contamination and soiling. So this is fairly an advanced topic. I'm trying to make it as simple as possible because there are a few advanced surgical options we need to adhere to. We need to adopt in terms of managing these wounds with frequent contamination, soiling, and additional moisture, various things that come into poor wound healing and difficult management of these wounds. So if I summarize all the places where these could happen, I think I'm not going to talk to you in detail about all these. The common ones are the stomal sites, the enterostomies or enterocutaneous fistulas, the fecal contamination with either multiple perianal fistulas, sphincter damage and incontinence and perforating, fungating anorectal tumors. And then urinary contamination with incontinence and various vesico-vaginal, vesicouterine, vesicocutaneous fistulas. These fistula is an abnormal opening between viscera and the skin. Then the wounds following debridement for necrotizing fasciitis and Fournier's gangrene, that is another sort of a necrotizing fasciitis that occurs in the genitourinary area or the scrotum or the labia in the female, that part. So the problems we face are the frequent contamination and frequent need to change the dressing. We heard how more cheaper dressings are more useful in minimizing the cost of or maximum utility of these dressings. And this contamination and accumulation of urine or feces leads to maceration, additional fluid, and then resistant infections, proteolytic breakdown of the wound bed, especially in terms of intracutaneous fistulas, where the proteolytic enzyme content is high, and overall leading to poor wound healing and sometimes increasing the depth of the wound itself. So this I'm going to skip because it's definitely beyond our scope. And the stomal and intracutaneous fistulas, they are most commonly the postoperative bowel injury or stomal creation sort of injuries. Then the Crohn's disease, tuberculosis, post-radiotherapy fistulation, or either malignancies, perforation, collection of fecal matter, and then they perforate out of the skin. And sometimes when there is prolonged surgeries and we can't actually close the laparotomy wound, we close using laparostomy techniques where we utilize various techniques to minimize intra-abdominal pressure, intra-abdominal compartment syndrome. So basically, there is a very thin layer of additional tissue between the bowel and the exterior, and they can give rise to multiple intracutaneous fistulas and frequent contaminating wounds. So these are a few examples of intracutaneous fistulas where you can see this is an abnormal connection between the bowel and the skin. And as you can see, it gives rise to contamination of the whole wound and a very difficult scenario in management and managing these wounds. These can also, like similar to the stomas, they can be high output stomas, meaning they can give rise to dehydration and electrolyte imbalances, calcium, magnesium losses, and especially when the stomal output is more than 1,500 to 1,000 24 hours. Usually the normal ileostomy drainage is about 400 to 600 milliliters. And these are high in proteolytic enzyme content, especially when the fistula is higher in the small bowel. And these give rise to maceration, skin irritation, pain, poor wound healing. And this also leads to malabsorption because more proximal these fistulas are, then the malabsorption is more and dehydration is more. And it's very difficult to control these, to attach a stomal base plate and contain these spills. And you need to adhere to various advanced techniques of combinations of stomal care and vacuum and advanced abdominal closure techniques to manage these. So modified base plate glues, two-piece stomas, zinc barrier creams, stoma vacuum combinations, and sometimes making these control fistulas and correcting the nutritional deficiencies, glycemic control, and sometimes octreotide to reduce the amount of intestinal secretions unnecessary. So then come one of the most common scenarios, the fecal contamination of wounds. It could be due to normal anorectum with close by contaminating wounds, either anal or rectal injuries, giving rise to sphincteric damage and incontinence, multiple rectocutaneous fistulas in various diseases like TB, Crohn's disease, and post-radiotherapy scenarios, and advanced malignancies, fungating lesions in the anorectum, and sometimes with normal anatomy, even diarrhea with a bed sore can make the matters very difficult to manage in normal setting. And these could also give rise to like internal enteroenteric fistulas, could sort of short circuit the colon and might give rise to very erosive sort of fecal incontinent or like fecal discharge, which can give rise to difficult scenarios in management of these conditions. So then there are different treatment options. One of the most important things I need to reiterate here is the temporary diverting colostomy or ileostomy, depending on the level of the problem. And then we need basic plus advanced wound closure and wound management techniques. Then negative pressure wound management systems. All needs to be used in concert to treat these patients. So one of the most important thing I need to tell you all is the diverting colostomy, that is to divert the fecal stream away from the wound so that the wound would not get frequently contaminated with the fecal matter. Then comes the contamination with urine. It could either be due to incontinence related to malignancies or problems related to urinostomy or urinary tract fistulation scenarios. So if I explain for you upper tract fistulas, like the common scenarios is partial nephrectomy, where it could give rise to fistulation of the pelvic calyceal system onto the skin. Then again, pyeloplasty, urethroplasty, when performed with a distal obstruction, it could release the pressure onto the surgical wound and give rise to fistulas. Then penetrating and blunt renal and ureteric injuries with urine leaking into the perinephric region, and then fistulation across a weak point into the skin. And then percutaneous nephrolithotomy, we use that as a renal access technique to get rid of the stones and tumors in the pelvic system, and especially we dilate the tract to various sizes, and if there is a distal obstruction and if we haven't used any stents or tubes to relieve the obstruction, it could discharge urine through these tracts for a longer duration, giving rise to contamination of the wound and giving rise to problems there. And then the lower urinary tract fistula, especially the gynecological surgical complications, vesicovaginal fistulas, ureterocervical, ureterovaginal fistulas, and vesicouterine fistulas. These are different types of fistulas that can be found in gynecological patients. And then rectourethral and rectoprostatic fistulas in different fistulating pathologies, and sometimes these are due to instrumentation post-radiotherapy, where you have irradiated the prostate for maybe prostate cancer or bladder cancer, and you do a biopsy and the wound never heals, and it gives rise to either rectoprostatic fistula or troublesome contamination of urine and mixing of urine and feces. And then vesicocutaneous fistulas can also be there. Sometimes they are non-healing suprapubic catheter sites with untreated bladder outlet obstruction, where the urine finds the least resistant part of the bladder. And so that's another scenario where urine could leak out from the bladder onto the skin. And sometimes advanced bladder cancers, advanced penile and labial carcinomas, where the urine finds it difficult to come out and it gets stagnated, infected, and gives rise to various complications. So this is a patient who had a fungating penile carcinoma, and he found it difficult to pass urine. And if you appreciate this area, this scar is actually the suprapubic diversion site, which patient did not want to have due to, I think, difficult acceptance of the disease, even though it is obvious. So treatment-wise, the most common investigations to identify urinary leakages is the CT-IVU, where you do various CT imaging, especially about 15 to 20 minutes after the initial contrast injection, to catch the urogram phase, where the urinary tract, the pelvic calyceal system, bladder gets lighted up with the contrast concentrating in the urine, or retrograde pyelogram, where you insert a ureteric catheter and inject dye into the pelvic calyceal system to identify the anatomy and any potential leaks or complete cutoffs. These are the uses of retrograde pyelogram. And we have different urinary diversion options available for us. We have either temporary or permanent percutaneous nephrostomies, where we put nephrostomy drains into the pelvic calyceal system to divert urine from the upper tract. And then the urinary stents, these are small plastic tubes that can be kept from, that actually divert internally from the kidneys into the bladder. And then the ureteric catheters and Foley catheter combination. So important concept here is to control fistula creation, or like you make the leak point more controllable, and you use colostomy, urostomy bags to collect and prevent soiling of the wounds with urine. And a very important thing here is to monitor the total urine output and the fistula urine output to make sure whether which way this management is heading, whether the fistula output gets diminished gradually or whether it is increasing and stays the same. So this is a diagram of a percutaneous nephrostomy where you go through the skin and the tube actually lies in the pelvic system and the urine gets diverted out of the skin here. And this is how it appears on the patient. So ureteric stents are polyurethane material stents, like could be single coil or double coil, and it runs from the kidney here and up to the bladder, bypassing the obstruction in between. And ureteric catheter is a small, slender plastic tube or polyurethane tube that is longer and spans the entire length from the kidney, ureter, bladder, and comes out of the urethra. So there are different tip configurations, different textures, different shapes and sizes which can be used. So the negative pressure wound management systems are also important concept, especially when used in combination of diverting urostomies or colostomies to divert the urinary and the colonic stream away from the wound to prevent contamination. This the negative pressure increases angiogenesis and removes excessive moisture to maintain and hasten the wound healing process. So this is a picture where the negative wound management systems are applied for excision of necrotizing fasciitis, and a case report of life-threatening Fournier gangrene treated by colostomy and VAC-assisted closure. And this is a Fournier's gangrene where the entire the scrotum gets sloughed off and there is necrotization and gas formation in the subcutaneous tissue. And when you exercise it, you can see the entire scrotum is necrotic, and because the blood supply to the testes comes from the abdomen, the testes are usually viable in except in very complicated cases and very delayed presentations where even the blood supply of the cord is also affected, which is very rare. And usually the testes are salvageable, but so once you excise all these things, and then we come to the reconstructive phase of it. And this is again a negative pressure wound management system is being applied here. Practical point here is very difficult to achieve complete sealing. You need to sort of shave off all the hair away, and you need to apply a lot of film dressings to make sure the dressing is tightly adherent and the negative pressure is being maintained. And sometimes this is a very expensive way of doing it, and you need to do this every few days because with the mobility, these skin crease and all give rise to leakage of air, and the whole thing needs to be redone. But this actually hastens the granulation tissue formation and wound healing. So we can quickly go on to this is a mesh grafting of the skin, and then again the VAC is applied here to faster take up of the graft. So this is another important device, especially in urinary incontinence, where you could collect the urine coming out of the penis using a condom catheter. So that is a condom catheter is a device worn outside, and it does not span the entire length of the urine. So this is not a type of indwelling form of a catheter. So it's a very simple device, but very useful in terms of preventing wound contamination in the perineal area with urine. So those are a few things I wanted to tell you all. Although this is fairly advanced in nature, some of these things are simple enough for our day-to-day practice, especially in terms of uh, these palliative patients. And I would like to discuss about a patient who had a advanced malignant ureteric obstruction and diversion, who went into bed sores, and then who we managed to get back to normal life after all these application of these wound care management protocols. And anyway, I think I've come to the end of the presentation. It's any questions? I would like to take any questions if there are any.
Thank you so much, Dr. Hilary. Very interesting. And as you mentioned, there are many more things and very advanced things that you could do. I will open the floor for anyone to ask any question, or you can give your opinions. If you have, if you have come across such patients, what have you done? Please, floor is open.
Yeah, being a urologist, we come across these Fournier gangrenes, which we have to excise large chunks of tissue in the perineum. And sometimes we come across polytrauma where the scrotum and the perineum is eviscerated with runover injuries. The sphincter is also gone. So this complex situation is often useful to divert the urine, divert the fecal stream away from the wound to prevent any contamination, and then to manage the wound separately. So those are different to the palliative setting, but still, I think the basic concepts of wound care are the same there. But I think the more common things in palliative setting is the bed sores that are running deep into pubic bones or pelvic bones, which get frequently contaminated with feces or urine, and preventing healing of these tissues. So in that scenario, so we can adopt these diverting techniques, either suprapubic catheter or indwelling catheters, and then you can get these the colostomies, diverting colostomies to get the fecal stream away, and also use these negative pressure systems whenever feasible. I would say these are very expensive ways of managing wounds, but gives good results, especially if the resources are available, and if you find the correct patient to do that. I think that's what I wanted to, the message I wanted to give is always think about the other surgical options of moving the contaminant away from this wound, like diverting colostomy, diverting urostomy, or suprapubic catheter, or even simple things like condom catheters or indwelling catheters to get the urinary stream away from the wound, where the wound could be managed in the usual way. I think that's the only thing I wanted to reiterate in this lecture, because to reiterate the fact that, again, this is where we could use multidisciplinary approach in the wound management setting, where the patient is the ultimate beneficiary. So I think that's all I wanted to tell. This is fairly advanced topic, but we need to know that these are common scenarios when in palliative setting as well. And I think the MDT management, the surgeons, the urologists, and the wound management team, where everybody has to sort of like contribute together for the well-being of the patient.
Yes. Anything else? Anyone wants to add? Okay, then. Thank you so much, Dr. Hilary, for your very interesting talk. And I'm sure we can further develop and discuss on this topic, because it is very rarely we hear, and you can concentrate on, on palliative care, palliative management, because I have come across, I think, 3 times with this kind of the exact picture what you have shown. One in India, 2 in India, 1 here. And one patient actually, he committed because of so many reasons. So very correctly you mentioned about MDTs, multidisciplinary teams. It should be, not only sometimes doctors, but sometimes psychologists, the counselors, sometimes clergy. The team should be, the palliative team should be, it's very multidisciplinary team. So, and twice we have, actually we have done the palliative sedation for such patients. And because they were in such a agony and, such a pain, and all the life was gone due to these kind of wounds. And so we have to do the palliative sedation for these 2 patients. I can still remember. So you all are doing a wonderful job, wonderful work. So thank you so much, Dr. Hilary, for giving your thoughts and your experiences about this contaminated wounds. Thank you. Then the last lecture of today and the last lecture of the session of the basic certificate course in wound management for medical officers. So Dr. Thusitha Kahaduwa, I invite Dr. Thusitha Kahaduwa to talk about wound prevention. So Thusitha, it's over to you.
Thank you very much for Samadhi. Well, we have half an hour, officially half an hour. And Thushan spoke about the bedsore prevention. So that is half of my job done. So let's talk about wound prevention. So now prevention, it's always better to prevent. Or are we just going to wait and advise on how to treat the wound? You know, it's good. The business is good if you let it happen, and there'll be repeated visits from the patient, and his pocket will get empty, your pocket will be full. So basically that's not, apparently that's not what we should be doing. So prevention is primordial, primary, secondary, and tertiary. All those concepts apply, do apply to wound care as well, prevention of wounds as well. And there should be prompt referrals, follow-ups, health education, health promotion, all that goes into prevention in primary care. So the primordial prevention of wounds. So here I'm talking about the foot wounds. So can prevent diabetes. I'm just proposing. This is what you should think about when you're preventing. You think about primordially preventing diabetic foot wounds. So likewise, you can have a system to prevent pressure ulcers as well. So healthy food habits, exercise, maintain activity level, correct weight to height or height to waist ratios, waist to height ratios. So stop alcohol and tobacco, that sort of thing. So waist to height ratio, by the way, should be around 0.4 to 0.49. So let's talk about the diabetic foot wounds, diabetic foot, how to prevent. So those are the majority of cases that we encounter diabetic foot wounds. So for that, mainly foot, skin and toenail care, patient education, protective footwear. And of course, there are protective surgeries. Those are rare options in Sri Lanka, but they are also there. And before going into foot care advices and all, we should understand why the foot. Why does diabetes cause foot wounds? There is actually a lecture, actually a public presentation in my YouTube channel discussing this, why diabetes cause wounds in the foot. Why does this disease affect foot? So why actually the human foot is a very complex organ. It has a lot of bones, and none of those bones are connected to each other with mechanical joints. Those are not stable. Can you imagine you putting up a foot on a table with the correct architecture? You can't, because none of those bones are connected to each other with mechanical joints. So a lot of other structures, tendons, ligaments, many things, muscles are needed to hold the correct architecture of the foot. So then that complex structure holds the whole body against the gravity. and a small derangement can cause grave changes in the pressure distribution of the foot. So that's some basic stuff. So what diabetes does is, neuropathy and vascular problems and all that causes nerves to dysfunction, and the necessary nervous tone to go down and to dysfunction. A certain level of intrinsic firing, or what you call it, nervous signaling is necessary to keep the muscle tone and the foot in correct shape. So that is gone. When that is gone, you get these hammer toes and all those deformities, flat foot and all that. So on top of that, you get the sensory dysfunction, peripheral vascular disease, and when there's an infection, there is the poor immunity and all that. So that's why the foot gets affected. And again, I'm reminding you that the human foot carries your weight all the time, and it hits the rough floor all the time. So to prevent foot wounds, we should do skin care, good mobility control, hydration, nutrition, foot care, and foot care. Those are the topics that we have to understand and practice. So in this photograph, you can see that's a callosity shaving. You can appreciate this. The shavings are from top to bottom. Top is here, the smaller ring is the top, and the larger one is the bottom of the callosity. So there are no wounding, just layer by layer shaving. So that is part of foot care. So foot care advices, they contain these topics: checking the patient's feet, nail cutting, moisture, and advices on footwear. So all these things you have to know by heart, and you have to dissect that into these in your language. You have to divulge that into to your patient in his language. So all your patients don't have the same capacity to understand. Their level of understanding, their education, all that is different. So you have to boil it down to those levels and then give the advices. And they are from various different backgrounds, various different trades. So considering all that, you have to give the advices. So there's I propose a 5-step technique. So this particular technique, give me a moment. So this particular technique, you can find it in my YouTube. So let's just. So before, first thing to advise a patient is on how to prepare. So before you practice this, you ask them to practice this 5-step technique. You have to tell them how to prepare. They have to dedicate a fixed time every day for foot examination. That is the best. And they have to use a diary. And they have to wash and clean the feet with lukewarm water and preferably wipe it with a white cloth so that they will see if there's any blood, pus, or any other ooze coming from your feet. So all those will be telltale signs. And they should have a well-lit place prepared. And if they can't examine on their own, they have to use a mirror. So bear with me, this is a little boring, but this is what you have to advise. So this is a 5-step technique. I propose that the patient should check their calcaneal area, the midfoot, hind foot, midfoot, and the forefoot, and then go into the in between the toes, and then check the nails and the skin in the dorsum. So what should they check for? Any cracks, blisters, pustules, any redness, any other derangements, fungus in the in between the toes. They have to push a little bit on the nail bed and see whether anything is coming out, and any wounds, scratches in the skin. So, and of course, they have to check the warmth of the plantar area and compare it to the same area in the other foot. If there's a difference, if there is a difference in the same area, that is alarming. So they have to report back to you. So all this should be recorded in their diary. So it's the same thing. So what about nail cutting? So you have to advise them to cut their nails, leaving a little bit and straight across. Not to trim it down to the edge of the nail bed. So after checking all that, after trimming the nails and all those procedures, they have to apply moisturizing cream or some lotion or whatever. You have to attend to the moisture of their skin. So that is very important because because of the derangements in the autonomic nervous system, you don't get the correct moisture in their skin in the feet. So you must have seen a lot of patients with very dry skin in their feet. So that dry skin will definitely give rise to problems. It will crack. It will be very scratchy, irritant, and all that. So at least twice daily, they have to apply some lotion, but not in between the toes. In between the toes, you have to put talc powder. So I guess that is clear up to now. Is that clear? Can you remember and advise now? Come on, guys. I need some answers. Otherwise, you are.
Yes, sir, it is possible.
Yeah. Okay. So somebody's alive. Okay, good. So this is there in my YouTube. Just remember, if you see a diabetic patient, please advise on these things. So, and now the next thing is to choose a footwear. So before going to footwear, we have to appreciate that now footwear is an extension of our feet. So what is it going to do if we say if you wear a wrong footwear? What is it going to do? there is this concept called the kinetic chain, where the spine, the neck, and all the other joints that transmit our weight into your feet, they will adjust themselves, automatically adjust themselves. If one is deranged, the other one will adjust. So all these are like rings connected to each other. Suppose if you wear a wrong shoe or a pair of shoes with one with a different height, so eventually you might end up with a back pain or a neck pain or headache, or your the knee joint will go. You will be doing knee surgery then. So that is one example. The other one is the most commonly what we encounter in diabetic patients are their deformities. All those deformities will be compensated by the knee joint, ankle joint, knee joint, and the spine, everywhere. So that's the kinetic chain concept. So you are directly dealing with the kinetic chain when we are advising on footwear. So here's another example. So even a collapsed arch can give rise to a lot of problems of the chain. So why do the diabetics need special shoes? We know they have neuropathy, they have foot deformities, and their fat pad has migrated, and the metatarsal heads and the other bony prominences are not protected as in a normal person. I guess everybody knows what fat pad migration is. And all this leads to wounding. So the other important thing is a proper shoe can be used to heal the wound as well. So see the before and after of this particular patient. So only the shoe. Not much was applied onto the wounds. So before going into advices, we should know some basic parts of the shoes. So the heel, the shoes in diabetic shoes, we talk about the outer sole, the midsole, and the insole. And there is the heel counter and ankle collar. So those are the important things. So we need a good toe box and a tough heel counter to accommodate any derangements in the Achilles tendon. And outer soles should be tough and lightweight. Should be adjustable and accommodating to any deformities. And there should be a padded inner surface that will not give rise to cuts. There should be extra depth for accommodating insoles. The patient might need an special insole, custom-made insole. Just a simple thing or two about toe box. And it should be spacious enough that the toes can wiggle a little bit, and it should be wide enough not to pinch the ball of the foot. Another thing is that the shoes with no seams and no reinforcements are better. The tongue is the ankle, not the ankle collar. This is the tongue is what you get underneath the laces. So should be padded so that the laces don't dig onto the foot. The opening of the shoe should be wide, and the rim of the throat, known as the collar, it should be padded. So I guess many of you all are awake. Are you?
Yes.
Okay, great. So the heel counter should be stiff. So we'll just run through this slide. So insoles, if those are removable, it's better. And a custom insert is the best. So midsole serves as a cushion, and the midsole may contain an arch support. Arch support is advised in diabetes. And outer sole should be resilient, flexible, and hard enough to not give not allow sharpness to cut through. So what not to? High heel shoes are bad. Slip-on loafers, those are these common Bata, and sandals that have straps between the toes. So about the shoe size, you should advise them to get the correct size. Not big, not the bigger one, or not the smaller one. And they should always do a test run. Just walk around the store and see. And if it doesn't fit, just how expensive or how better the brand and all that is, just leave it. So that's about the footwear. So we spoke about footwear, skincare came with the foot care. So food mobility control is okay, and hydration and nutrition we spoke earlier. So that is prevention of foot wounds. And of course, you have to follow up on your patients with his primary physician or surgeon, the diabetologist. So you, the primary care person should be the hub, referring and getting referrals back. And you must refer. And health education is very important. You have to use every opportunity to promote healthy lifestyle, prevention of diabetes, and of course, foot care and footwear and all that. And health education is simply put that know what you want to say and just say it. And use whatever innovative way is possible. So prevention of bed sores actually Thushan did. I just wanted to say that bed sores. The body is not supposed to get bed sores. It's in a balance not to get it. So the factors that those were discussed during the lecture push them towards getting a bed sore. And our task is to establish the balance back again. So all this was discussed. And another thing that I want to highlight is that in bed sore prevention, there are only 3 things to do. You should do it. You should get your assistants to do it. You should get your nurses to do it. Just look, and look. And it's always, at least once a day, some healthcare person should look for bed sores, new developments, and the possibility of having a bed sore, prevent everything, and put the pillows at the correct places and all that. Look, and look. So that's another video in my channel as well. So in summary, we spoke about diabetic foot wound prevention as well as pressure ulcer bed sore prevention as well. So that's the end of the presentation. So thank you very much. Are there any questions? Are you still awake?
Yes.
Great. So I think this is quite straightforward. Only thing is that you have to repeatedly read these things, and you have to have it in your tip of the tongue, and always use all the opportunities to educate your patients on this. Just know what you want to say and say it. So I guess there are not much questions on this. Are there any questions? And talk about a little bit more on diabetic shoes. There are diabetic, there are diabetic shoes in the market. Most of them are suitable to for diabetics with no deformities. It's not for people with deformities. So with people with deformities, you have to have this kind of a shoe. And those are also available in even in supermarket pharmacies. So there are special shoes for diabetics without foot complications, and special shoes for people with deformities, and there are special shoes for people with wounds. Those are healing shoes. They can be adjusted. The insole can be removed, can cut a piece or just fix another piece here and there. And there are a lot of adjustments in those healing shoes. And then there are custom-made shoes for people who have undergone amputations, serious deformities, and people who have had Charcot's feet. So those are, you have to measure their foot pressures and do a custom shoe. So, are there any questions? And another thing is that if you see a callosity or a cone, in a diabetic, those are definitely going to give you trouble in the long run. They will be they are basically wounds. So to prevent a wound, you just have to just shave it off. You'll be saving a limb. What is the treatment for callosity? Yeah, callosity is you just shave it, not cut and suture. Just shave it off layer by layer. Slowly take it off. And end of the treatment, you should not end up with a wound. It usually doesn't. And you have to follow up these patients with recurrent callosity formation in the same place. You definitely you have to correct the footwear. You have to alleviate the pressure on that place. Now, no point in just shaving and shaving. Correct the footwear. If it doesn't work, there's usually a time period that the skin thickening occurs. So sometimes it's 3 months, sometimes 1.5 months, and the patient knows. You have to review the patient in that after that time gap and then reshape it. Are shoes same for both leprosy and diabetes? Yeah, kind of yes. Both neuropathy.
For cones, is it shaving effective? Callosity, it's okay.
Yeah, shaving in the sense the cones you have to pull it out and shave.
Pull
You
it
have
out
to
means
basically cone you can catch the cone. First you shave it. Shave the there's a thickening around. Then you can actually catch the middle of the cone. It's very coarse and callous. With a mosquito you can catch it and pull it out and slowly avulse it.
What about cone plasters?
Not for diabetics. It just gives trouble. It just damages the normal skin as well. A size 15 blade used for shaving. Yeah, it can be used. I am used to number 11, but 15 is better if you are not really fluent in handling number 11. Number 11 has a very sharp, very pointy edge. 15 is better to start.
If you had to remove a cone, what is better? It is suturing or kept it open? Keep it closed.
No, that's what I said. You should not end up with a wound. Cutting and suturing is not the treatment for a cone or a callosity. Just shave it down to the normal skin. Even for a cone, you can do it. What about AGO inwards lotions for callosities? No, they won't work.
Salicylic acid, is it?
Urea works. I mean, it works. Why do you want to put salicylic acid? You can just shave it off. And it will give the corn plasses also contain salicylic acid, I guess. The diabetics, you should not damage any other thing, surrounding skin or whatever. So you're just giving more trouble. No?
Is there a place for steroid injection for painful cones?
Not at all. The cone is painful because the pointy tip of the cone is irritating the skin. You just have to pull it out and remove it. You can actually get an actual cone if you do it properly. Liquid nitrogen for callosities, I don't think shaving is the way to go. Liquid nitrogen, I mean, you are just giving the patient ice burn, isn't it? Where to get reliable diabetes shoes, where measurement to be taken, tailor-made, and patient is not overcharged. Yeah, there are few places. This is a recurrent problem. But 2 or 3 places that I mean, there are 2 places actually they have podiatrists, but I'm not very fond of their outcomes as well. But there's a place around Vattala. They are quite good these days. It changes with their podiatrist, but there are various other places that they have just declared themselves doing custom shoes. They just do a shitty job. I mean, that's they don't just go for them. They know nothing, and they will make life difficult for you. Just make your patient's life difficult. They just make something. They don't know about offloading. They don't know about foot arches. They don't nothing. So the best thing is for you to learn a little bit about offloading forefoot, midfoot, and hindfoot, and practice it. And you can advise your patient to how to uh, cook up his own footwear. There was an SLMA project called Nirogi. I designed some shoes for from the Nirogi project, and those were all around the country as Nirogi, DSI Nirogi. So I think with the that was a CSR project. Those were very cheap and all, but they killed the production line after COVID because they could not do the CSR. But now the same designs came out as another brand from one of their subsidiary companies. So I'm not because this is not a funded lecture. I'm not going to discuss that this thing, the brand and all. And they are MOU with the second brand also had an MOU with the SLMA that also ended. So so that's why I'm not going to introduce that brand here. So but those they have some you know I designed 3 sets of shoes for them, and those are okay, and there are they have to fully covered 2 types as well. Those are from India. I didn't design those things. Those doesn't serve any purpose, and those are actually detrimental because they have pointy toe boxes, and they are tapering in the front foot and all that, and they doesn't serve any purpose in preventing wounds. Others are okay. but they are quite expensive now. And those can be there's one healing shoe, it's quite expensive, that can be customized. Are there any questions? Other questions?
Yeah, I see none. Now, I think we can conclude, no?
Yeah. There are no other questions. We can conclude the session as well as the lecture series as well.
Yes.
Excuse me. May I know what is the dressing after this type of sparring or shaving done for callosities?
Basically nothing, because there are no wound. If the patient is afraid of walking on that, you can just put a gauze and plaster, and say if you cut a little thin, you shave and you are not very sure of the integrity of the remaining skin. Just ask them to put a gauze for protection for about 3 days. That's enough.
Okay, thank you.
Where do we send the assignments?
You have to email.
Yeah, to the college email that was in the e-flyer. We can put it here, no? CPMSL
Office.
office at CPMSL.
It is on the chat box also.
Excuse me.
Yeah.
Some asked to use some pads, gel pads for shoes for the patient with callosities. Is it a good practice for them?
It is okay. You have to shave off the callosity and see. I mean, what's the deformity there? If it's a simple thing, just a fat pad migration and the foot is sort of intact, a gel pad will help. Gel pad will definitely help. It will lengthen the duration of the callosity, the recurrence of the callosity. But that is not the best thing to do. The best thing to do is alleviate pressure on. For that, you need a customized insole. But good gel pad will actually help. But not
Where
for
can we buy
severe deformity. Yeah.
Where can we buy the customized shoes?
Customized shoes, there are, I said, there are 2 places that make them, and they do customized insoles as well. So, but only one of those places are good at the moment. Depends on their podiatrist. Since we don't have podiatrists in Sri Lanka, we actually, if you are doing wound care, you have to be your own podiatrist. You have to know the kinetic chain, you have to know the foot mechanics. Foot mechanics, it's a different topic. So in an advanced food care course, we can discuss food mechanics. That's about 1.5 hours of a lecture, but that's a lot of practical experience, a lot of science as well. So you have to have a basic idea about food mechanics. How, say, if you elevate this part, what happens to the other parts and all that. If you are by trying to reduce one caloricity, you might give about 3 caloricities the other side. But most of the time, people wear the wrong shoes. If you correct the shoe, the footwear, caloricities will go. Are there any other questions?
What about cracked heels? How do we handle that?
Cracked heels. Cracked heels actually needs a lot of moisture. No? So there are various food creams. Urea containing ones are, I think, better. And a lot of moisture. And for some, it's seasonal. I don't know whether they have to be referred to a dermatologist, but usually don't. No? So maybe a kind of eczema as well.
Okay, then. I think we can conclude. And this recording also will be updated to our YouTube. Actually, now then this brings the end of the basic certificate course in wound management for medical officers program organized by the College of Palliative Medicine of Sri Lanka. Actually, during this 1 month period, we had few of our council members, particularly Dr. Ranga Pereira, who is a consultant oncosurgeon, and Dr. Thushan Gunarathne, the consultant vascular surgeon, Dr. Kitsiri Senanayaka, consultant surgeon with special interest in endocrinology, and Dr. Hilary Fernando, consultant urologist, and of course, Dr. Thusitha Kahaduwa, who is pioneered in wound care in Sri Lanka and doing a wonderful service. So, and Thusitha is the coordinator of this course. And throughout the sessions, we had our president-elect, Dr. Janaki Vidana Patirana, and the secretary of the college, Dr. Kumudu Veerakon. So I must thank all of them because all these lecturers did their work in voluntary basis. And I'm sure all the participants got a lot of knowledge, fresh knowledge, and I think it's eye-opening thing for your day-to-day practice, what to advise, how to take care, how to manage wound properly. And this training, this practice brings you a good doctor, a quality doctor, and your patients as well. They will get the maximum out of your knowledge, and you can treat them, properly and scientifically. And I saw quite a good interest in doing palliative care. So palliative care is still a a growing field in Sri Lanka. We still have a diploma in palliative care at PGIM, but very, very soon we will have a MSc program at the Faculty of Medicine, University of Moratuwa. All the MBBS doctors are eligible to do that. So I invite you all, if you all are thinking to enrich your knowledge in palliative care and with the Master of Science degree, so there will be opportunity. And once again, we have a international journal. I think this is the only college with the international accredited journal, indexing journal. So we have posted some links to your WhatsApp group also. So please feel free to publish your research, your findings, case scenarios, systemic reviews, etc., on the journal. And again, I'm inviting you all to be a member of this proud, prestigious College of Palliative Medicine of Sri Lanka. And still, we are allowing doctors with MBBS, but very soon there will be a, some other specialties will join, because with other informations also we need to get it. So anyway, thank you so much of joining these sessions. On behalf of the college, I must thank you all. And don't forget, next week is the deadline for your assignments. So if you all are struggling with the assignments, use the WhatsApp group or in our emails. Feel free to ask anything. So we are there the faculty is there to help you. And only when you submit your assignment, only then you will get the certificate. The certificate, we are not just issuing the certificates. Who successfully completed the course and the assignment. So please write your name properly as you wanted to appear in the certificate, and please send your postal address also, in case if you need a hard copy of the certificate. If not, we can send you the e-version. You all can print it out. But if you feel you need a hard copy, so write your name and your postal address also, because you all are from everywhere, not only from Colombo. If Colombo people, you all can collect it from the college office, but please write your proper name, how it should appear in the certificate, and your postal address. So use the WhatsApp platform for that. So I think this is the end of the session. Thank you so much. Dr. Thusitha, you want to say anything?
Yeah, thank you very much for joining the sessions and the keen interest and the interesting questions. And there's another question as well. One last question: what is the management for including toenail? It's actually surgical. It is combination of surgical as well as antibiotics. I mean, if it's infected. It's SADEX procedure. You have to do the SADEX procedure, and if necessary, you have to give antibiotics. So, and yeah, of course, thank you for all the questions, the interest, and please. we will be conducting more programs on wound care, probably another advanced course as well, and we will be repeating this. If any of your colleagues miss out on this, they can join in about 2 months or so. We'll be repeating this during this year, and then we'll go into an advanced course. So thank you very much again, and hope to see you in session, our scientific sessions, and of course in future programs as well. Thank you very much, and good night.
Thank you. Good night.
Good night.
Thank you. Good night.